All right, good morning, everybody. Thank you so much for the folks who are here in person with us. And to everyone who's joining online, my name is Dr. Sarah Oltmann. I'll be our moderator today for our session on the thyroid cancer management benefits of the multidisciplinary team approach. The panel today is sponsored by the American Association of Endocrine Surgeons. Today, joining me for our panel, we have Dr. Nancy Perrier from MD Anderson. She is a professor of surgery and chief of endocrine surgery at MD Anderson. We have James Suliburk, who is also chief of endocrine surgery at Baylor College of Medicine. And then we have Dr. Sarah Hamidi, one of our newest oncologic endocrinologists at MD Anderson. So please help me in welcoming them to our group talk today. Okay. So today's format is going to be case-based examples that will kind of highlight how a particular scenario may be handled at a center with a multidisciplinary team approach. We will let our panelists weigh in at the end of each case and then open it up at the end of each case for any questions relevant for that particular topic. So we'll go ahead and get started. Our first case today is a 25-year-old woman. She underwent a total thyroidectomy roughly a year ago with a low-volume surgeon at a small community hospital. She was found to have a 5-centimeter, a very large papillary thyroid cancer. It was said to be classic with no other concerning findings. No lymphadenectomy was done. Before she could undergo radioactive iodine, she became pregnant. Her endocrinologist is not an endocrinologist who specializes in thyroid cancer either, and so she was started on Cytomel, and so for several months had her TSH ranging between 500 or 50 and 100. And she got referred into your multidisciplinary clinic to try to figure out next steps. With the assessment, she now has masses in her thyroid bed. It's unclear if these are new or not. And her unsuppressed thyroglobulin is 16. She still has 4 more months left in her pregnancy. So now she wants to know what's next. So how does your team assess these types of patients initially treated at another facility? And what information for y'all is really important to verify or double check? And how might that information help us interpret what's been going on here? So Dr. Hamidi, how about we start with you?
So usually when we see a new patient that was treated outside, we kind of just want to kind of double check, like you said, that all of the diagnosis was the right ones. We have our pathologist review the slides at our own hospital, just make sure, was it truly papillary thyroid cancer? Can we gather extra information? And sometimes, not too often, but sometimes we get the pathological diagnosis change when our own pathologist, who has bit more experience reviewing thyroid cancer slides, review the slides, and then we try and get the images from outside, all of the surgical report, kind of gather all of the information that we can to understand what was done before, and then we get repeat imaging at our institution because, again, similarly, our ultrasonographists are very used to doing thyroid ultrasound and mapping the neck, and so we get repeat imaging at our institution to get more detailed assessment and kind of go from there.
And then Dr. Suliburk, as far from a surgical standpoint, what are some different things that you would think about in this situation? One, you have someone who's not been suppressed. So, is this truly recurrence? What is the scenario that's perhaps made this recurrence more likely, or is it residual disease that wasn't cleared out? How might that initial verification step change your interpretation of this?
Yeah, so a few things on this case. Number one, this is actually not an uncommon occurrence, unfortunately. And actually, we have an integrated clinic that we have a couple of our endocrinologists that actually specialize in women who are pregnant and having acute endocrinopathies, one of them being thyroid cancer. And so immediate steps for us are to get a baseline laboratory evaluation and health evaluation of how is this woman doing from an overall health standpoint, and then integrate our maternal fetal medicine or OBGYN specialists into the care of this patient, in addition to our endocrinologists and our surgeons and our pathologists, just like Dr. Hamidi said. We're going to collect all the relevant information on what was previously done. We're going to do some immediate evaluation to understand what the current TSH is, what that thyroid hormone replacement is, in order to make sure that we have a healthy pregnancy, and involve our OBGYN specialists, maternal fetal medicine as needed, to make sure, number one, that we stabilize this woman's health. She's got 4 months left in her pregnancy. Review all the relevant data and information. Once we get a background for that, we may or may not request molecular testing on the original pathology. We will, of course, do the imaging. We know there's a difference in, especially in sonography, in imaging at experienced centers versus non-experienced centers. And then we'll get that multidisciplinary plan together for this woman. And of course, finally, we'll, once we have our end of the thing involved, we're going to also engage in shared decision-making with the patient, so that we can get her through not only this disease process, pregnancy, but create that whole overall comprehensive multidisciplinary plan.
And then, Dr. Perrier, the patient is very anxious about all of this. She's not had good counseling to this point. She wants to know, when should surgery be to address this? Does this need to happen during the pregnancy? Do they need to try to deliver her early? It's not infrequently that I will get calls from the OBs saying, well, we can bring her in and we can deliver her early if that's necessary to be able to make sure we get cancer management. So how do you think about this? And is this necessarily an aggressive presentation, or is this just simply a presentation that's resultant from inappropriate medication?
Thanks, Sarah. I would approach this patient with a significant amount of calming and healing, because in the big picture here, this is a papillary thyroid carcinoma in a young woman, and the outcome is favorable. If this was an incomplete total thyroidectomy, a near total or a subtotal, and thyroid tissue was left around the recurrent laryngeal nerve or the parathyroid glands, it would appropriately hypertrophy when this woman was rendered hypothyroid from not a superb replacement regimen. And from all the details that you've told me, if this, I'd want to know what the post-op PTH and calcium were. I'd want to know what the post-op TG was, because this is probably not even aggressive recurrent cancer. This is probably regrowth that's appropriate of thyroid disease that was left in situ. And I would calm the patient to this fact off the cuff. I'd also do what Sarah and James acknowledged, and I'd probably, for reasons to help her, do an ultrasound guided FNA to get the tissue, to have our pathologist confirm, is this just colloid regrowth? What's the pattern of this regrowth? Are there locally advanced lymph nodes or not? Probably not, and you've already said that the nodules are in the thyroid bed, or I'd want to confirm that. But regardless, I think she's not a candidate for radioactive iodine. And in fact, even if she wasn't pregnant, I'm not sure that at our institution we'd give her radioactive iodine under any circumstance, because she's so young. So I would let her continue this pregnancy and deal with, work through this, get her appropriately replaced for the rest of the pregnancy, and then deal with this afterwards. I think that the mentality that we are trained to cure, and that's what we train for technically. But even when we can't, or, it's a matter of timing, we can always heal. And what I think about this patient is, oh my goodness, how much angst.
Yeah.
Right. And so let's heal that. That baby is being created in a body of a woman that's just nervous and thinks she's facing her own fatality, which is probably way too over aggressive in thinking. So I'd approach it that way. I would want to know what the PTH and calcium were. Was this lady, again, a little hypopara? Are these often when you do a really good ultrasound back in the central neck, you see nodularity there that might in fact be the residual parathyroid glands that were left there, or appropriate, you know, there might be some reactive lymph nodes. So I just calm it down a little bit.
Perfect. So any questions on this particular case or scenario?
Hi, maybe not so specific to this case, but just in general, at what point do you recommend molecular testing? Do you like it as a baseline, or if you just want to sort of target for drug therapies or somewhere in between?
Who wants to handle that first?
So, like Dr. Perrier said, this woman's going to do very, very well overall. And she is highly unlikely to need any additional adjuvant therapy. Having said that, we try to characterize our significant thyroid cancers, especially ones greater than 4 centimeters, so that we have that as a baseline reference in the medical record, in her longitudinal care plan. And so it's done, it's checked off. BRAF testing is very straightforward these days. And then we have that as a data point in her overall history moving forward. And so I think that when we talk about genomic analysis of pathology specimens, we're moving into an era where that's really going to become standardized. Just like the histology is standardized, we're going to have genomic profiles of all our patients' tumors and what those look like, so that in the rare instance that we need to deploy targeted adjuvant therapies, we will know what the molecular profile of that initial tumor was. And then perhaps if this is a long time down the road, we may even recharacterize it to figure out what it is at the here and now. Be happy to. Nancy?
Yeah, I was just gonna nuance that a little bit. Maybe we do things different. We don't get molecular testing on everybody up front. Yeah, we in our group, what we tend to do is get the BRAF testing in most patients with a BRAF IHC. So just test specifically for BRAF, because this helps us specifically make decisions about radioactive iodine, because we know that patients that have a BRAF V600E mutation tend to not respond to radioactive iodine. And so in cases like this, we tend to just get a BRAF IHC to help us decide. And then it's with patients with more advanced disease where we foresee systemic therapy in their future. That's where we're going to get more comprehensive testing, when we know that most likely this patient's going to need systemic therapy in the next year or two. Then we're going to test either their tumor, or if there is disease at that time, then we might want to biopsy that to get more updated information about what their tumor looks like at that time, where we're going to want to treat them.
And then just to clarify while we pass it over, IHC is just a type of staining of the slides as well. So it's after the specimen's already out, it's very easy to go back and restain that if the slides are still available. It doesn't necessarily, it's not a blood test, it's not a cheek swab. So that particular one is very easy to do on the final pathology.
And to complement what Dr. Oltmann was saying, this is on the pathology specimen. This is not preoperatively on an FNA. I mean, we're going to have the entire specimen. We'll be able to dissect what is normal thyroid tissue, what the tumor is. And so it will live in perpetuity in the path lab, and that information will be there and be available.
And some patients, if they have molecular testing up front with their biopsy, we may have the benefit of knowing BRAF status before surgery. But again, it just becomes a single data point, and it's really put into context of everything else that we see with the individual tumor itself, the rest of the thyroid. So up front, it won't necessarily change our operative plan. However, it's helpful for us to know as time evolves and things are behaving, how does it change?
So Dr. Hamidi, you had mentioned if it's BRAF positive, it's less likely to respond to radioactive iodine. So what's your next step if it is BRAF positive?
So it's just, what I meant by that is that if we go back 10, 15 years ago, everybody would get a total thyroidectomy and then radioactive iodine. And so nowadays, we don't do that anymore. We try to personalize care much more. And so if I have a patient who is just had thyroid surgery. I know that they're BRAF positive. I know that they had a good surgery. Dr. Perrier operated on them. Their thyroid globulin is undetectable. Then I'm not going to give that patient radioactive iodine, even if their tumor was like 5 centimeters, even if they had some more aggressive pathological characteristics. If they have a undetectable thyroid globulin, a BRAF mutation, I know that I'm going to be following that patient. I won't give them radioactive iodine. And my next step would be monitoring it. At that time, they don't require additional treatment.
All right, and then we're going to move on to our next case. So this case is to more so talking about ultrasonography and imaging long-term. We have a 43-year-old female. She's presenting for surgical evaluation after her initial biopsy of her thyroid was done with a low-volume surgeon. The initial ultrasound done outside just showed a single suspicious nodule, nothing else in the thyroid, no mention of the lymph nodes. The biopsy of that nodule came back suspicious for papillary thyroid cancer, not necessarily diagnostic. And that low volume surgeon initially recommended a lobectomy to the patient. The patient comes to your office for a second opinion, and as part of your assessment, a lateral neck mapping is performed, and there's several very large lymph nodes detected. And so can you guys talk a little bit about, when you're seeing a patient for a second opinion up front, how do you process their workup done to date? What other things do you add? Does this necessarily need to be done in radiology? Can you do it in your office? And I'm going to direct these actually to Dr. Perrier and Dr. Suliburk, since this ends up being usually coming to the surgeon's office.
Thank you. So the importance here is the mapping and the context of what's the extent of this disease. And so a complete ultrasound, including both thyroid beds, the central neck and the lateral neck bilaterally, is really of importance. We're not going to do this. I'm personally not going to do this in our clinic because we have an entire clinic that is run by a neuroradiology group that only does head and neck ultrasound, and it's part of our institution and it's part of our culture. So I'm going to have that ordered when I see this patient coming. I'm going to ensure that in the new patient business office, and understanding why they're coming, that before they even see me, they're going to have a comprehensive ultrasound, including both lateral necks, central neck, and the thyroid. And I'm going to write on that order FNA as indicated. And I want, more importantly, I don't want them, and working with them closely, which is a dynamic interactive process. We might communicate by text, by phone. We all know each other pretty well and hold each other accountable. I want them to put a needle in that lateral neck lymph node. I don't care so much about the nodule in the thyroid. I want to know, because if the lateral neck node is positive, then that alters and that gives me an operative plan. And then if that is positive in this 43-year-old patient, I'm probably going to want a cross-sectional CT of the neck. Because if she does have bulky lateral nodes as described, and again, that's not going to be ordered at the same time, but it's going to be ordered in succession and planned, and we're going to wait. And the team is going to know that ultrasound, FNA, it comes back, she gets a CT scan before she sees me, because I do want, and I'm in lateral neck disease and in bulky disease, as you said, I if it's large nodes, I do want to know the extent of that, how high lateral, and I want to specifically know what's going on in the central neck down into level 7. We know that level 6 is at the top of the clavicular sternum, but the ultrasound's not really good at looking below that. And what we want is for this operation to be the right operation. And we want all disease extirpated. And so I'm willing, not in every case, but in this case, to get the CT scan, even though the patient's going to get iodine with that, because it's worthy to the treatment. The successful cure is surgical treatment. That still remains the number one answer.
Well, and still the operative planning time, but until you're actually going to give radioactive iodine, it's going to be 2 months at least. So the iodine load will have washed out easily as well.
Yeah, and I would, And again, in part of this, if she has any hoarseness, again, with bulky disease, is the bulky disease just in the lateral neck? If so, then I'm not so worried about it. But if there's anything in the central neck or where the primary is, or and
We'll
on,
get to that part later in
Perfect.
another case. So don't steal my thunder. So Dr. Suliburk, if you want to then kind of build off that, specifically talking about also the interpretation of the images, even if the right images are captured, but the interpretation of the images and what the images look like may vary from place to place based on the tech, the machine, the technology.
Yeah. So all our patients, we wish that everybody had the fine-tuned machine that is Dr. Perrier's MD Anderson, right? But we know that we've got to also elevate the playing field for everybody.
Yeah.
Right. And so modalities that we'll employ here may be surgeon performed ultrasound, or the experienced endocrinologist performed ultrasound in the clinic. So patients, you'll be looking for someone who's maybe ECNU certified. If you're seeing an endocrinologist, that means they've done some extra training in ultrasonography to be able to identify these types of patients. Or you want someone who is a specialist seeing thyroid cancer. Not all endocrinologists are highly experienced with it. And of course, we know you want an experienced surgeon. If that surgeon employs surgeon-performed ultrasound as part of their physical examination and their initial evaluation of the patient, they'll be able to identify these nodes. And then, in my practice, that's frequently what we'll do. And then we'll get a CT scan, just as Dr. Perrier mentioned, because we know the limitations of ultrasound. The level 7 area, that means sort of right here at the top of the sternal notch. Also the retropharyngeal nodes, another sort of hiding spot that the ultrasound beams just can't get there. And frequently, depending on the patient's body habitus, how bulky the thyroid is, may be limited in the level 6 areas as well. So cross-sectional imaging traditionally gets a little bit of a, we're going to avoid that. Ultrasound's the gold standard. And by cross-sectional imaging, we're referring to thin cut CT scans with contrast of the neck, non-contrast of the chest as indicated, and not needing to go for PET scans, not needing to go for MRIs, but focused CT scans of the neck and chest. Nancy?
And then I guess one other thing. So if your lateral neck is just showing, like, say, 1 centimeter suspicious looking lymph nodes, are those patients necessarily getting CAT scans as well?
It depends on their risk factor.
Okay.
If they've got a family history,
Okay. Yeah, fair enough.
if they have a occupational exposure history, then certainly we're going to employ CT scan. If it is very isolated and fairly small volume, and they're otherwise low risk, then we're just going to stick with ultrasound.
Okay, just wanted to kind of highlight that to make sure we're setting fair expectations, so not everyone's running back saying, I need.
Great point. Thank you.
And to complement what James was saying, Sarah, again, coming at this this scenario without confirmation bias, are these lymph nodes just reactive lymph nodes, right?
Correct.
A total, like, I don't want to think that we've thrown the cart before the horse. Let's look at this, because this just might be, a thyroid nodule that's incidental, and these might be reactive lymph nodes.
Correct.
And in that case, we're not going to get a CT scan, right? And we're going to, again, put the needle and confirm it's benign. But again, if it's rounded, if it's got a fatty hilum, if it's not taller than life, they're all those important things. So acknowledging to everyone the judgment that comes in along the way.
Yeah.
And that's why it's very important for the patients to seek out experienced personnel in the management of this.
So the question in the back is, should there be any concern for a patient who had a total thyroidectomy with a nodule less than 2 centimeters? Concern about whether or not their lateral neck was looked at? I guess you guys can't necessarily. So let's go on the assumption, if a patient had thyroidectomy, their primary tumor is less than 2 centimeters, does it matter if their lateral neck is looked at? I know the answer, but can you guys?
It does matter. The lateral neck is a comprehensive neck exam should always be performed.
Yeah, I think all of us have seen tumors in the thyroid that are less than 1 centimeter and lymph nodes in the lateral neck that can be several centimeters in size. So primary tumor does not at all relate to lateral neck involvement.
Yeah, so I would just say that for the patients, the take home there is, if you're being assessed for thyroid nodule and for a potential oncologic indication for operation for that thyroid nodule. You should ensure that what's done is called lymph node mapping of the neck on the lateral neck
Or
as well as the
nodal
central neck.
surveillance, something along those lines.
Normal
depending.
preoperative workup. That's standard.
And then question in the room here. So the question in the room and whether or not it's variable by thyroid cancer type, but will it bypass the central neck and potentially go straight to the lateral neck lymph nodes, or can you have distant metastasis elsewhere without it necessarily being in the lateral neck? Let's give this to Dr. Hamidi.
Yeah, so usually, as long as I know, if we have a lateral neck lymph nodes, we usually have central neck lymph nodes for the types of thyroid cancer that like to go to the lymph nodes in the neck, so mostly papillary thyroid cancers. But some subtypes of thyroid cancer are going to bypass completely the lymph nodes in the neck and can cause distant metastases. And we're talking here about follicular thyroid cancer or oncocytic or Hurtzel cell. These can bypass the neck and just go through the blood vessels and cause distant metastases.
And then Dr. Perrier and Dr. Suliburk, in your experience, is there a sweet spot in the thyroid the tumor might be that causes it to go straight to lateral neck and bypass central neck?
I think the data is suggestive that, higher pole thyroid malignancies are a little more likely to traverse to the lateral neck. And I do want to acknowledge that we don't usually do sentinel lymph node mapping in the thyroid because it's a very vascular gland. And that attempt in the 90s, there were a few studies when sentinel lymph node mapping was really taking off with both blue dye and with the gamma probe for melanoma and for breast. And the thyroid is just too bloody of a gland. And to put the blue dye in it, it washes out too quickly. And so no one was ever really able to prove what the accuracy of a single lymph node that would be predictive. That would be great if it was, but the blood supply is just too varied. It's the thyroid is a really bloody gland, and cc's per second, it has a higher volume than the liver. Our liver surgeons never want to acknowledge that, but it is true. So we don't really rely on sentinel lymph node mapping, but thank you for bringing that point up for us to acknowledge that.
All right, we're going to move on to our next case. Our next case is to talk a little bit about some of the nuances of how a patient's finances may weigh in on decision making. So this is a 25-year-old gentleman. He presents to the county hospital after a car accident, and he's found to have a neck mass. He's cash pay, does not have insurance. He was able to get set up for a biopsy of this mass, and it did come back as PTC. Otherwise, it looks like that nodule that's 2.5 centimeters is his only lesion. There are no concerns about lymph node involvement. He has some concerns about his ability to follow up. And so how might access to care, insurance coverage, or stability of insurance coverage change your counseling about lobectomy versus total thyroidectomy?
Okay, so it's a great case because this is my whole world I live in. Half my time I spend working in our county hospital here at Ben Taub Hospital here with Harris Health System in Houston, Texas. Third largest public county system in the United States next to Parkland, where Dr. Oltmann works with UT Southwestern, right? So a lot of experience here. So first of all, oncologically, this patient just needs a lobectomy. No question about it. And the fear factor driving the patient to want a total thyroidectomy because they can't do close monitoring and they're worried about spending extra money. What I would say to that patient is, listen, you're going to do very well. There are things that we don't fully understand about taking out all the thyroid that could put you into an even deeper financial predicament. We know that patients can have neurocognitive dysfunction following parathyroidectomy if they're permanently hypopara. We know that patients frequently will complain of brain fog if they don't have optimization of their thyroid hormone replacement post-total thyroidectomy. And that can lead to even more problems with financial toxicity, okay? And so in these types of patients, we stick with the science. And the science is that a lobectomy is absolutely the appropriate oncologic extent to resection for this patient. And that concerns of, well, I can't follow up, so I want everything done up front, that fear driving that, we need to, as Dr. Perrier says, be very healing, be very patient-centered with our conversation with this patient, and sort of walk them back from from the ledge there a little bit and say, hey, here's what the science is. And we understand what your fear is, wanting everything done right here and now, but that could actually put you in an even more challenging position financially.
And I would just add that doing a total thyroidectomy puts him at higher risk of hypoparathyroidism, at risk of hypothyroidism, which we could potentially avoid by doing just a lobectomy. And hypothyroidism and hypopara, especially hypopara, are conditions that need long-term follow-up. And I would argue hypopara is even harder to treat than thyroid cancer. So these are things that we want to avoid, especially in a patient that cannot follow up long-term. So definitely a lobectomy would even be a better option.
Okay, question from the room?
Yeah.
So the question for everybody on Zoom is, what resources or contact people should we direct patients to if they're in this situation where they're having to go out of network, out of pocket to help get the appropriate care?
So everything is geographic specific is the short answer. So depending on where you live, there will be different resources and there will be different qualifications for financial assistance depending on your geographic location. And it is literally variable at a
County
zip
level.
code county level, right? And the state of Texas is very county specific. Other states may be slightly different. It gets very complex. At a just overall level, you would say, okay, where is the experience center in my geographic region? What types of patient assistant programs are in place at the experience center? Almost, I would tell you, every center will have social workers and case managers who will know what resources are available in your local area. And that's where patients should be directed to an experience center with the personnel who know the appropriate information for assistance.
I think 3 good points to bring up. I love this discussion. The first is, I would acknowledge to the patient as well that even I would want to know what his pre-op TSH and T4 work, because even with just a lobe, there remains a possibility that he's going to need supplement. And that possibility depends on the preoperative labs. And I assume, and we know if the TSH is higher than about 2.2 from the data that is available in the literature, there's about a 20% maybe chance that he might need supplement. Now, this is not total replacement, but it might be a little supplement. So just ensuring that upfront we're at least setting the tone and educating that he might need a little, he's not totally out of the woods with just a lobe. Number one. Number two, from a technical standpoint, as we talk, I always like to acknowledge this man needs a lobe and an isthmus. And that's a technical point, but the isthmus needs to be removed so that the remaining thyroid tissue that hypertrophies, which is appropriate as it regrows, we don't want that isthmus tissue to regrow onto that ipsilateral side, because if he ever needs a completion or a reoperation, that's putting us in a reoperative setting. So you want to do the lobe and you want to come right across the isthmus. And the third thing is, I agree that this man is a perfect candidate for a lobe and an isthmus because of his inability to sustain adequate thyroid hormone replacement medication, not being insured. But I'd be a little cautious with the absolutes that we use, because we just really don't know. I know that in our Thursday morning conferences every week, we have people with brain mets, lung mets, bone mets that started off as 1 centimeter papillaries. They started off small and we don't really understand. So I'm just a little more, and I know that the pendulum does swing. I think hypopara is a technical, I think it's a bad problem, but I think the solution to that is to train people to respect the paras even more. And I'm not quite as adamant about, educating the patient on a lobe or a total, although on this patient, I would counsel him for a lobe. But I just don't want y'all to leave the audience thinking everyone, absolutely, a lobe is right for everyone every time. Because it's a good operation, but it's not the only one.
Okay.
If he does get only a lobectomy, and you're already worried that he can't follow up with supplement with the Synthroid or whatever long term, but if he has PTC and you're not sure of the stability long term, isn't the way to keep it from coming back by suppressing the thyroid by using
That becomes part of the double-edged sword of all of this. And
Well, so levothyroxine GoodRx generic Walmart program is $12 for a 90-day supply. And so the expense for the patient comes more in the laboratory monitoring of adjusting the levels. That actually becomes fairly significantly costly, especially when you're paying cash to LabCorp, Quest, any lab test now, all that stuff.
he needs that regardless.
He's going to likely need that regardless. And quality of life data wise, the quality of life data would say that he will be much improved quality of life with a lobectomy and still some native thyroid tissue than simply having a total thyroidectomy and really being sort of all over the map with no native thyroid tissue and only levothyroxine replacement with limited access to quality follow-up and adjustment, right? That's sort of the rubbing point here. Statistically, he's very likely to do extremely well with an isolated 2.5 centimeter well-differentiated papillary thyroid cancer and no other disease anywhere else. He's most likely going to do very well. And so we would, again, thinking about this in a probabilistic term, we're going to go with what the data show us to be the best course for him and not let fear drive too much of an over-aggressive resection.
This is still a very hot topic of debate. And I think the new guidelines, when they come out, will be very helpful, further providing structure and guidance one way or the other. I do want to move on to the next piece of this. So in my location, I would counsel them for a total upfront because they're going to get the labs regardless. And their ability, at least in our system at Parkland, to get labs is pretty easy. We do have a pretty good survivorship clinic in that particular location, but he did end up getting a total, and his final path did actually reveal some increased levels of concern. It was a tall cell variant, and because of that, now we're recommending radioactive iodine. So he did get the right surgery up front. His job, though, he is working on heavy machinery. He's by himself, so he's not having to isolate, but he is having to move forklifts around, and so he has to be very mentally sharp. So he has some real significant concerns about his time off of work and lost income if he withdraws for radioactive iodine, but he's equally concerned about the out-of-pocket cost for Thyrogen. How do you help this patient weigh their options?
Well, I don't think there's a right answer here, but I would just start by saying my first step would be to make sure that this patient actually needs radioactive iodine. You mentioned tall cell variant. Tall cell variants tend to have a BRAF 600E mutation. So we are very, I know it's not what's in the guidelines or it's not common practice, it's not what everybody does, but we at Anderson really weigh that into our decision making if we're giving radioactive iodine or not. So my first step would be, do I really need to give this patient radioactive iodine? But let's suppose we actually do. I think, again, I'm not sure there's a right answer here. If we're doing TSH withdrawal, there are some ways where we don't need to stop completely the hormone for 4 weeks. So there's data that we can potentially decrease the dose by half for the first 3 weeks and then just stop it for 1 week. Or there's also ways of supplementing with Cytomel, which is shorter acting for the first 2 weeks where we're stopping the hormone. But we still need, at some point, the patient is going to be off thyroid hormone. And the data shows that even if we're doing these things with the Cytomel or reducing the dose, the patients still experience hypothyroid symptoms the same way. And since this patient's job is at high risk, I don't know that there's a way of having him continue work all along. And so I think that if we're doing TSH withdrawal, he would have to be off work for a little bit of time prior to his radioactive iodine treatment and then for a few days afterwards while he's isolating. And then with Thyrogen, he probably won't have to take as much time off from work, but of course it's an expensive medication or drug. So I think here's just weighing which would be less expensive for him. But unfortunately, I don't think there's a way of having him not lose money at all in this situation. But I
In
don't
his particular work job, he doesn't work around anyone else. So going to work, he's not around anyone. He's solo by himself. So he's still technically isolated. It's just simply the mechanical acuity of his, yes, as far as his mental concentration for what he needs to do. So yeah, I think finding out at the particular location, what is the cost of Thyrogen and how does that compare to the cost of the lost wages? And then it becomes a math equation to figure out which is going to be ensuring he gets the care that he needs. So
Speaking of your questions, I have insurance that covered Thyrogen. They have a patient assistance.
In the past, so I work at Parkland Hospital for several years. Our patients could not, and Thyrogen did not provide a patient assistance. With some changes, at least within our county indigent program, our patients who had the Parkland financial insurance could get it covered through their pay. The Parkland employees, however, who worked at Parkland and had the employee insurance couldn't get it covered and they had to pay out of pocket if they wanted it.
So similar experience in Harris Health. There is no patient assistance program from the company. And we have predefined criteria that patients on Harris Health's financial assistance program will meet. And if they meet, then the county will provide them Thyrogen as part of their benefits. But the county employees on the county insurance, again, it's all based on what your benefits are.
So we'll move on to our next one here. This is talking a little bit about post-op, some voice concerns. So this is our patient here is a 65-year-old gentleman. He had a very locally aggressive follicular thyroid cancer. He had his surgery with a high volume surgeon. The nerve was found to be encased for a very large segment of it. And so it had to be resected. He's now struggling with severe voice weakness as well as swallowing and some aspiration concerns. He does have some medical comorbidities that make the concern about aspiration in him a little bit higher risk than our average typical patient. So who on your team helps the patient through this? What resources are available for them? And then based on the findings, does this weigh into future treatments, other additional concerns with how the vocal cords end up getting managed at this point? Injection, temporary versus permanent, a tie back of one of the arytenoids, that kind of thing.
I would start with, did we know this nerve was out preoperatively? Again, in helping to plan, did the patient present with hoarseness? Was he at high risk?
It was a functioning nerve intra-op, even with nerve signal, and the patient had a little bit of weakness, but during the surgery, they had a strong signal, but it just plowed into the tumor. They tried opening the tumor, the nerve kind of just fell apart. It wasn't able to be traced.
Okay, and so again, understanding that conduction pattern. So this is post-op. So we would have the patient seen by our video stroboscopy team, our voice. We have a voice clinic and video stroboscopy. We would not do anything unless he was aspirating, and you did say he was at increased risk, Sarah, or he was. We usually sit tight for 6 weeks, maybe even for 12. We would put him on reflux precautions, make sure he's on antacid, make sure he's educated about elevating the head of his bed, just anything to prevent. But a good assessment with a video stroboscopy gives us the opportunity to have it taped, have it recorded, have it available in the medical record, have it available for comparison in the future. If this is irritation, reflux, what's the compensation of the other nerve? Is this an anterior fold problem with the cricoid? So just to have that data, but it would, we would not want to do anything permanent immediately to see how the compensation was. He's 65, but we would be slow if he is aspirating at that 36-month mark. We would not be hesitant to have either injection is temporary, let that ride, but then put in something permanent. And then you add
injections too can be either permanent or temporary too, just depending on what they use.
And that would be, again, based on whether the nerve was actually resected and then what kind of compensation or what kind of improvement we saw over a period of time. And then you talk about future and how that affect in the future. Screening him, looking for recurrence on the contralateral side, right? That'll all fall into play.
Yeah. Based on this is a functioning nerve preoperatively and an advanced tumor, probably are also going to have some component of the superior laryngeal nerve dysfunction here that's likely triggering some of the swallowing and aspiration issues, as well as the recurrent laryngeal nerve. And so for us, we're going to do postoperative education of the patient, chin tilt down, head turn. That generally will pacify things so that they can go through their activities of daily living and get prompt laryngology evaluation, just as Dr. Perrier said. We're going to get them in promptly within 1 to 2 weeks with our laryngologist, and they're going to do the video stroboscopy, their direct or indirect flexible laryngoscopy, whichever laryngologist is working the clinic that day. And then they're going to make a decision as to what further therapies that patient will get. The first decision, general pathway, is immediate speech pathology evaluation, doing some more advanced exercises other than chin tilt and head turn maneuvers to strengthen the swallowing mechanism, strengthen the larynx and pharynx. And then our people usually are going to use a temporary injection and direct, where we're going to do an injection. They're actually able to do it in the clinic now when they're pretty slick. So it doesn't require a trip to the operating room, but they'll do an injection, temporary injection in the affected side in the clinic, and then expectantly manage that patient. Once we start getting out into that 3 to 6 to 9 months, then, as Dr. Perrier said, we'll be looking at more durable options. But, I think the key for the patients, if you're experiencing this type of thing, early evaluation by an experienced laryngologist definitely leads to better outcomes.
Yeah, and so making sure with the specialized centers, it's not just often a general ENT, it's usually specific otolaryngologists who have additional fellowship training in laryngology specifically, and then their whole clinic is set up with speech therapy right there in the clinic with them. And so it really becomes a very dynamic partnership to help move forward with any of those swallowing and speech pieces. So just ensuring, if for your surgeon, regardless of your surgeon's background training, whether it's endocrine surgery or ENT, making sure if you're having any troubles with your voice after surgery that you're getting that early referral, and that someone's taking a look to see what's happening on the inside.
Yeah, that's such a critical point, is that just like you're going to go to your experienced thyroid surgeon to have your thyroidectomy done, for voice follow-up, you need an experienced voice surgeon. That's going to be someone who's a laryngologist, not just a general practice ENT.
So any questions on the voice before we move on? All right, our last case today is long-term remission. So our patient's a 45-year-old woman. She was diagnosed with her thyroid cancer 15 years ago. She had total thyroidectomy, central neck, radioactive iodine, 2 years later, lateral neck. Now, 13 years out from the last operation, TG still completely suppressed, and no evidence of local regional recurrence on the ultrasound. So when does this patient get to go to survivorship? When does the TSH suppression lighten up? And then what constitutes a survivorship program?
So I can start, and then my colleagues can fill up. But so what we at Anderson have our survivorship program, and we have like specific criteria on when we can refer patients to survivorship based on their staging, so how extensive their initial tumor was, but also what their thyroglobulin looks like, as there evidence of still nodules in the neck that look suspicious that need more careful follow-up or not. But in a case of a patient like this who had, let's say, a low-risk tumor initially, or is very multiple years from their initial surgery with an undetectable thyroglobulin and normal ultrasound, then definitely this is a patient that can transition to survivorship and could have probably done so several years prior. What the survivorship program means, it's pretty much the importance of survivorship program is that you're still followed at a institution, well, at least for our case, with high quality imaging, and you're still part of the team. So although you're not followed anymore by your doctor per se, our survivorship program is led by APPs, but you're still there working closely with us. So if they have any questions, any concern, they can come back to us anytime. And you're still getting the same high quality ultrasound, still getting your thyroglobulin at the same lab, so it can be compared to your prior testing. And then the further away we get from surgery and we have no evidence of disease, of course, the less likely that the cancer is going to come back. So eventually, after a few years, we can space out the ultrasound evaluations. Typically, our patients are still getting labs yearly for at least the first 10 years, and then even the labs can be spaced out, but they're still going to be seen in clinic yearly just to touch base. And then our focus is still detecting recurrence, but again, the further away we're getting from the initial diagnosis, if we don't have disease, and we also start talking about things like bone health. Do we really need the TSH to be that suppressed? Probably not. If 13 years later, there's no evidence of disease, probably this patient can have a TSH that's in the low normal range, like 0.5 to 2 in our lab. And we start talking in the survivorship clinic, they're also going to make sure that your other cancer screenings are up to date, that your vaccinations are up to date, kind of like a general health vision rather than just being focused 100% on the thyroid cancer recurrence, but this is still one of our main focuses.
What are some of the consequences of having your TSH suppressed? I mean, we talk about it right after surgery as it being appropriate for certain cancers, but if we don't need it anymore, what's the downside of having the TSH so low?
Yeah, so osteoporosis is a big one, or osteopenia, weakening in the bones. If we suppress the TSH long term, it can weaken the bone, especially in older women, because already after menopause, women are at higher risk of osteoporosis. But there's also heart complications that can go on, so atrial fibrillation and so on. And just being over suppressed can also just make you more fatigued, cause symptoms per se. So if it's not necessary, then for sure we shouldn't be doing it. And with patients with low risk tumors or multiple years after their initial diagnosis, if they're doing well, then most likely you don't need TSH suppression.
And then are there any additional nutritional concerns? You mentioned cancer screening. Is there any particular cancer screening that would differ from the general public?
Unless you have a particular hereditary condition that predispose you to the thyroid cancer, that can also predispose to other types of cancer, which is a relatively rare situation, then otherwise it's just the general screenings like the rest of the population. And nutrition-wise, there isn't any specific diet that, let's say, is going to decrease the risk of thyroid cancer coming back or anything like that. It's just, again, having a healthy diet, kind of following the same general recommendations as the rest of the population.
I think that what Dr. Hamidi just finished there with is very important in patient education and survivorship. I've seen a number of patients who've sort of been taken advantage of by some of the nutraceutical industry and the supplement industry, where they sort of get sold taking all these different health and wellness supplements that cost a lot of money, just cost every bit as much as prescription money. And so I think it's very important.
Sometimes even more.
Even more, absolutely.
Because it's all cash pay.
Or get sold, your next cancer screening, your full body MRI, or your full body CT for your next cancer screening. Oh my gosh, you had a cancer. We need to make sure we screen you for any other cancers and get this fancy scan that, oh, by the way, it's $1,000 and we only take cash. Seen a number of patients who are sort of vulnerably preyed on by the industry. So having your experienced team counsel you just exactly like Dr. Hamidi did, very, very important part of ongoing survivorship in thyroid cancer.
So for those online, the question was, as people get further out from treatment and are transitioning into the survivorship bucket, whether it's formally called that close to home or not, how do you juggle those changes in your thyroid cancer management with additional age-related changes like perimenopause and the additional? And
I have a recurrence.
So you're
Okay,
being watched
so-
for disease that's still there.
you have stable
Okay.
disease that's being monitored.
Yeah. Yeah, so I think it's really a risk benefit kind of situation. So things have been stable for 6 years. I don't know how big the disease is, but we have to weigh how beneficial we think being very aggressive in TSH suppression is going to be. And so very often, like if I take a more extreme situation where somebody has atrial fibrillation and they really cannot be on any TSH suppression, then we just won't suppress their TSH. And that's okay as long as you're getting appropriate follow-up, we're keeping an eye on things, where you're getting annual ultrasound or whatsoever, seeing your doctor every now and then as long as you're getting the appropriate follow-up. And then if you can't get TSH suppression, that's just fine. TSH suppression is just something that helps, but especially in cases where disease has been stable, then you might, and let's say you have severe osteoporosis, you have fractures, then I just won't suppress your TSH. I would aim a low normal 1, and I would just keep a close eye on things, and that's just fine.
Just like follow up. What if like those aren't issues right now? The concern is balance. So like suppression is obviously kind of where it's being pushed, but I want to make sure I don't end up in those situations. Do you factor that into it as well? When the person isn't having those problems, do you keep them suppressed, or do you just slowly balance it out?
You mean you want to make sure that you're not going to develop
Yeah, I'd
bone?
rather not have any of those things happen.
Yeah, so of course, I mean, again, we don't want to be too aggressive in our TSH suppression. So if you're like appropriately suppressed and you're having the appropriate follow-up for postmenopausal women that need bone densities and all of that, then if you do develop one of these complications, we are going to catch them at an appropriate time, be able to manage them. And then if you do develop them, we can go down on our TSH suppression. Yeah.
Any other questions from the group? Oh, we have several. We have a couple in the room. We'll start in the front here.
Does it change if this person did have a reoccurrence that was more involved, like the reoccurrence had spread and they had a radical neck dissection and there was lymph nodes found in the neck and chest down towards the thymus? Like, is there a specific protocol that says how that changes how long you have to be followed up?
I think some of it is also going to be during that follow-up, what's happening. So you may have had a very aggressive upfront presentation, but if we're seeing after that appropriate treatment, things have stabilized and there's no evidence of ongoing progression or new locations, then you're slowly able to kind of de-escalate. And those of you who are able to visit or listen to Dr. Sosa's talk yesterday about the upcoming guidelines, she kind of emphasized at the end, based on some questions about your initial risk assessment and then the risk assessment over time, whether we're kind of de-escalating or escalating someone's risk based on the behavior, how things unfold over time.
So what do you do though? I get what you're saying about the risk assessment, which is something they commonly do now. But like in my case, I was diagnosed 30 years ago. They didn't do all that. Like there's no record of a risk assessment, but they told me, oh, you got the good cancer, you'll be fine, go on. And then 10 years later, I got a reoccurrence that was shown to be aggressive.
And sometimes that's hard. Well,
So saying is in a case like that, where you've had a reoccurrence, which now makes it appear that it was more aggressive than what they led you in the beginning, is there a number of years that you should be more suppressed or that you should follow up? Is there a difference in protocol as far as getting a CT scan or something rather than just doing a yearly ultrasound of the neck?
So, right. So, as I said, the whole treatment period. So number one, this is a completely dynamic thing. And what we do today is not going to be what we do 10 years from now. Right. And what we did even 8 years ago, 10 years ago is not what we do today, because everybody got all their thyroid taken out for, a 2.5 centimeter thing. 10 years ago, everybody got a total thyroidectomy, ipsilateral, central neck and radioactive iodine. Right. And so what we're emphasizing now is a comprehensive assessment initially. We want to know the full extent of disease, where that patient is at starting point. And then we're going to optimize therapy, surgical resection, good quality surgery, removing all the macroscopically diagnosed disease at that index surgery. All right. And that means the thyroid, all of it, part of it, and associated lymph nodes that we've characterized. And then moving forward, we're going to measure the TG, and we're going to then keep treating that patient for evaluation for disease recurrence versus disease persistence. Okay. And If you have sort of disease-free interval that's really significant, then all of a sudden you have a recurrence, then we want to say, okay, is this a very small microscopic recurrence? Is this a macroscopic recurrence? And if it's a macroscopic recurrence, then the clock's going to reset. Because if you have something that requires a big intervention with a big macroscopic recurrence, meaning you've got stuff that we see on the imaging, your TG numbers go crazy, and or maybe they don't because it's dedifferentiated, right? That's something that we worry about too, right? And you have to have an aggressive resection, then the clock resets. And then we start moving forward again.
I think all of us too have taken care of patients who, like you said, you were told it's done, it's dealt with, forget about it. And then they're not getting this monitoring with ultrasound, including nodal mapping. They didn't get it up front. Their TSH wasn't optimally suppressed. And oftentimes those recurrences that are picked up 10, 15 years later actually is just persistent disease that was there at the day one and just slowly growing because of suboptimal control.
From the beginning, I was
But were you getting the
That's okay.
imaging?
labbing scans for the first 5 years, the ultrasounds yearly after that. So when the reoccurrence happened, I had been being followed, and I had been being followed every 3 months with thyroid globulin and TSH and all of that. And then, and my thyroid globulin levels did not go up. The recurrence was discovered on an MRI for a herniated disc, and it lit up the neck and it lit up some lymph nodes in the chest. So it was, you know, I don't think it, in other words, I don't think it was disease that was laying there. I could be wrong.
Yeah,
but
you-
it was, because nothing had lit up for all those years. And then all of a sudden, from the November visit to the March visit, there it was.
So I think these are good points for wrapping up the whole scenario of, as Dr. Oltmann said, that really could have been persistent disease more so than recurrence. That was just slow growing, but the punishment should fit the crime. 20 years and we've got no growth and no stability. Those are our suggestions of moving to surveillance clinic, which is a little less aggressive because we don't expect more surgery, right? And then the minute we see something macroscopic or recurrent, then you come back in through the envelope. You come back to the surgical clinic, which is the treatment. You come back for resection. But the beauty, Sarah, of how you started and how we're ending, I think, is to highlight the education of the patient and the communication with the patient. So for instance, taking thyroid hormone replacement therapy, the importance of that. In every scenario we saw, whether there was regrowth, whether it was the pregnant female, whether it's the discussion with the young 25-year-old, or whether it's how we manage surveillance, but having people educated on how to take that medication consistently, reliably, on an empty stomach, and really so that they have a stability through their lives so that they don't have hyper or hypo. And how we tweak that is really starts up front with expectations. And that's what we can do at places like this and make sure that whether it's the mid-level providers or whether it's the survivor clinic, how we monitor that. And I thank you, Sarah, for starting and ending, because that's a good message for all of us here. And we appreciate your time.